I'm Rod Rourke, and I'd like to welcome you to this edition of the PRS Journal Club podcast with your hosts, Drs. Jordan Frey, Chad Purnell, and Dr. Shuja Shafqat. Please enjoy.
Hi, everyone. Welcome to this April 2017 edition of the PRS Journal Club podcast. My name is Jordan Frey, one of the PRS resident ambassadors from NYU, and I'm joined, as always, by my co-ambassadors, Shuja Shafqat from Lehigh Valley and Chad Purnell from Northwestern. Today we have the honor of being joined by Dr. Hani Sbitany, Assistant Professor of Plastic Surgery at the University of California, San Francisco. Thank you very much, Dr. Sbitany, for joining us for this PRS Journal Club podcast.
Thanks for having me. I'm thrilled to be a part of the Journal Club this month.
And the article we'll be discussing next is Microsurgical Reconstruction of Traumatic Lower Extremity Defects in the Pediatric Population. And this is from Stanford and University of Pennsylvania by Dr. Arash Momeni, Michael Lani, Dr. L. Scott Levin, and Dr. Stephen Kovac. And remember, everyone listening, all this month's articles can be read for free on prsjournal.com, including an archive of all past Journal Club articles. So to summarize this article, as we know, microsurgical lower extremity traumatic reconstruction is a challenging task, and especially in the pediatric population, that presents a unique subset of patients who have traditionally been considered higher risk for this type of reconstruction. There's different patient and physiologic factors that have been cited as these increased risk factors in pediatric patients, including small vessel size and increased vasospasm. And really most reports of lower extremity microsurgical reconstruction in pediatric patients focuses on oncologic defects. However, as we know from the adult population, traumatic defects can be more challenging to reconstruct given the inherent zone of injury involved. What the authors did is they looked at all patients under 17 years of age who had lower extremity traumatic microsurgical reconstruction at Duke University and University of Pennsylvania, and this was from 1997 to 2012. They reviewed these patients retrospectively, and they performed subgroup analysis of patients under 12 years of age, looking at patient demographics, flap and recipient site characteristics, intraoperative variables, and complications. In all, they identified 40 patients, 37 were male, 3 were female, and they had an average age of 11.4 years. And these 40 patients underwent 40 flaps for traumatic lower extremity microsurgical reconstruction. The most common sites were the dorsal foot, the middle and distal tibia, and calcaneal defects. They used muscle flaps in about 58% of cases, with the latissimus dorsi being most common in that subset of flaps, while the remaining 40% of cases used fasciocutaneous flaps, with ALT and parascapular flaps being most common. And they did use a single bone flap, being the fibula flap. The most common recipient site vessels were the posterior tibial, and they, in general, describing their technique, they used couplers for venous anastomoses and interrupted nylon for the arterial anastomoses. Mean operative time was about 400 minutes, and they estimated the mean blood loss was about 275 milliliters, each of which were not associated with the type of flap being muscle or fasciocutaneous. They monitored patients postoperatively using a Doppler as typical, and they dangled gradually after 2 weeks of elevation. So these pediatric patients were strict bed rest, presumably for about 2 weeks. The mean postoperative stay was about 13 days, and the return to full weight bearing occurred on average at 2.6 months. Looking at their complications, they had no cases of intraoperative flap loss. 4 patients required a return to the operating room for either arterial or venous anastomotic revision, and 4 patients additionally had to undergo re-exploration for thrombosis. Flap loss was noted in 5% of patients, so their success rate was quoted at 95%. They noted no donor site complications and few recipient site complications. Looking at their complications, they found they weren't associated with flap type, age, BMI, or the anatomic location of the defect, and they identified that they performed secondary procedures in only 10 of the 40 patients. And in the subgroup analysis of patients under 12 years of age, they identified 2 patients who required emergent re-exploration for arterial or venous thrombosis, and both of these patients were salvaged. In their discussion, they note that as the success has increased, microsurgery has been more readily employed as part of the reconstructive elevator, and while small vessel size and increased tendency for vasospasm have historically been identified as issues in pediatric microsurgery, they know that really they didn't observe much vasospasm and that they didn't really determined that the vessel size was an issue in their series. Although this wasn't measured explicitly, this was their anecdotal observation. And they know that theoretically in children, vasospasm may actually be less of an issue given the lack of a completely developed muscularis level, and that relative vessel and perforator size in children may actually be larger than adult populations. And other advantages in the pediatric population is obviously the lack of comorbidities, lack of atherosclerotic disease, and venous insufficiency. So they conclude that microsurgical reconstruction should be offered to the pediatric population. I thought this was a really interesting paper, and it describes a relatively large series, as these are not common problems that are encountered, and presented by two senior authors who obviously have a lot of experience and are experts in microsurgery. But it was really interesting to hear their thoughts about the issues, given that historically really vasospasm and the small vessel size have what they've quoted as potential downfalls in microsurgery for these pediatric patients. So Dr. Sbitany, I'm interested to hear your take on this paper, and also just in general what your gestalt or algorithm when you're encountered with these problems in the pediatric population is.
I thought this was a fantastic article. Obviously, we're reading an article written by two senior authors who specialize in lower extremity orthoplastic reconstruction, and so have a significant experience in these types of operations. And it was really interesting to kind of read through their algorithm and just their overall experience doing these operations in the pediatric population. We know through all our own personal experiences, including that of my own, that this is a challenging population to perform lower extremity microsurgical reconstruction on because of the aspects that you just summarized. Really, vasospasm and smaller both recipient and donor vessels. From my standpoint, like the authors of this paper, I will routinely perform free flap reconstruction in the lower extremity for the pediatric population when that is their most beneficial option for reconstruction. The only thing I would say that I do significantly different than in my adult lower extremity patient population is number one, flap choice, and oftentimes number two, the method of anastomosis. I would say for the pediatric population, I'm more likely to routinely go for larger muscles that I don't use as often in the adult population, mainly the latissimus muscle, because we all know that especially in the younger children, this oftentimes is for lower extremity defects going to be of the best size in their underdeveloped muscle options. And number two, because of the smaller vessel size, if anything, when I perform pediatric microsurgery of the lower extremity, I'm less likely to use a venous coupler, and I'm more likely to hand sew the venous anastomosis as I do the arterial anastomosis, because the smaller couplers, at least in my mind, are sometimes a little more difficult to use. But overall, I have to say I agree with kind of the experience and the outcomes that these authors present here in this outstandingly written paper. It kind of mirrors my own personal experience and probably mirrors the experience of most of us that are doing pediatric microsurgery for lower extremity reconstruction.
What do you do in terms of the anastomoses being performed end-to-end or end-to-side in this population? If you theoretically have a pediatric patient and after the trauma has 3-vessel runoff, do you alter how you would do that compared to an adult, or what is your opinion on that?
I think this is a really important consideration because with the anticipated growth and development that these young children are going to continue to go through in their lower extremity, we obviously don't want to do anything to compromise vascularity to their developing extremity. So my preference is, if at all possible, to perform my anastomosis to the anterior tibial vessels based on location of the defect and accessibility of those vessels, and of course, assuming they're outside of the zone of injury. When I have to go to the posterior tibial vessels, because they are the primary blood flow to the foot, I do try to go end to side when those are going to be the recipient vessels. Because again, I don't want to create a situation where the posterior tibial arterial flow is lost to the distal foot. So in general, if I have to go to the posterior tibial artery and vein, I try to do the arterial anastomosis in end-to-side fashion. Certainly, we all know it's going to be more challenging in this population because the vessels are so small, but I think it's necessary to at least attempt an end-to-side anastomosis so that we continue to maintain full perfusion to the developing foot and not in any way cut off its blood supply.
Thank you. Shuja, what did you think of this paper?
Yeah, I have to agree. I think it was an excellent paper. I think having this many patients in their series was impressive. I mean, we're at a pretty big trauma center, and I can't say I've seen too many patients in the past couple of years that would fit into this category. So I think that that's pretty good as well. Things that stood out to me was mean time to full weight bearing of 2.6 months, which I think was excellent and kind of speaks to the healing potential of kids, and kind of like Dr. Sbitany said, the high number of muscle free flaps that they used in their patient population, which is not really borne out in the adult literature. So I thought that that was interesting. One thing I would have liked to see more is discussion about types of anastomoses. Dr. Sbitany just talked about that, but they didn't really talk about their technique, whether end to end or end to side. They did say that most of their veins were hooked up with a coupler, but didn't really state if any were sewn. And I agree that trying to use the 1 millimeter or 1.5 millimeter coupler can be frustrating. And they also didn't really talk about preoperative imaging. So those are my kind of takes on it. But I wanted to ask Dr. Sbitany, they didn't really talk about using more than one vein. And in their tables, it looked like they had just used one vein for one artery or one vein for each flap. Do you routinely try to use dual venous drainage for lower extremity reconstruction? I know it kind of depends on the location of the defect, if you can use greater saphenous as another venous outflow or not. But do you routinely use that, whether in adults or pediatric population?
That's a really important consideration in reality, both in the pediatric and in the adult lower extremity reconstruction population. But certainly in the pediatric population, I always try to hook up two veins when available. I think it's so critical, especially if we're talking about reconstruction below the knee and certainly in the distal third of the tibia and on the foot, because we all know that venous drainage is going to be blunted in these distal defects for our free flaps. And so to enhance our outcomes and reduce our risk of congestion as much as possible, I always try to hook up two veins and use a dual venous drainage technique when possible. I think your point to anastomosing one vein to the deep system in the leg and one to the saphenous superficial system when possible is a great one. And I think also if the authors here, and I commend them for this, used a fair number of fasciocutaneous flaps in this population, which is very challenging in the pediatric population. But if you're going to use fasciocutaneous free flaps, I think it's even more important to hook up a dual venous drainage system, because those tend to be the flaps that more readily experience venous congestion in the lower extremity, and at least in my experience. So when I am going to use an ALT or a parascapular flap, 100% of the time I try to hook up two veins.
And then kind of a little bit jumping off of that, they talked a little bit about their dangling protocol. And I know that that's sometimes a point of contention between different experts in microsurgery as to how to do dangling protocols. Some people wrap, some people don't wrap, some people let them dangle, some people have a specific protocol. Do you have a preferred dangling protocol, and does it change for adults versus pediatric patients?
I do have a very specific dangling protocol, but I have to admit that it does not differ between adults and children in this setting. So I use the same dangling protocol. I also have to admit one disclosure, which is that I trained in microsurgery with the two senior authors of this paper, and I happen to think they're masters in this field. And so I use the same dangle protocol that they described in this paper, mainly waiting a couple weeks before starting any dangling and then slowly allowing them to experience longer and longer periods of dangling over the first few weeks. And so I employ a very similar technique in my practice to what the authors in this paper describe in their practice.
Thank you. Chad, what did you think of this paper?
I really enjoyed this paper, and in the cases where I've had to do some pediatric free flaps, it always makes you a little bit nervous because there's a lot riding on the case, but also there's this sort of perceived extra level of difficulty with doing a pediatric free flap. And what I thought was reassuring about this paper, in addition to that large series of free flaps out of Boston Children's, is that in reality, if you look at large series from expert microsurgeons, they're actually getting essentially similar results in doing pediatric microsurgery that other surgeons are getting in adult series. So I thought in a lot of ways, this is a kind of a reassuring manuscript in that if you are an expert and if you do enough of these cases, you can actually get results that are similar to large series from adult surgeons. So Dr. Sbitany, I wanted to sort of jumping off of that, some of the things that authors have talked about that make pediatric free flaps so difficult are vasospasm and small vessel size. What's your experience with those two issues in performing pediatric microsurgery? Have you really run into additional vasospasm in children? And is it true that the relative perforator size in children is actually better than in adults?
Those are really important considerations. First, I'll take vasospasm. I do think that there is, at least clinically, a somewhat greater incidence of vasospasm in the pediatric microsurgery population. And really, if you think about it, it doesn't occur in the free flap itself. By definition, that free flap has undergone a sympathectomy when you harvest it and cut its artery and vein at the donor site. It's really more so in the inflow vessels in the leg. At least in my experience, the anterior and posterior tibial artery in the pediatric population tends to be much more sensitive and prone to vasospasm. And really, again, in my experience, it's something that you do have to account for. And so certainly intraoperative agents like papaverin, vasodilators, and muscle relaxants are things that I do use more aggressively in the pediatric population, as well as a warmer operating room. And I think those things alone have helped to somewhat overcome the relatively higher amounts of vasospasm that we see in the inflow vessels in the pediatric population. Certainly, vessel size kind of overall is smaller. These are smaller individuals. And so, again, their vessels do obviously tend to be smaller than in the adult population. And in my mind, that's where, for those surgeons who have had lower rates of success with the pediatric microsurgery, that's really the key issue, dealing with just smaller vessels. It's like for those of us who have made the jump from doing microsurgery to super microsurgery, there's a learning curve. And just the smaller vessel size alone makes it more challenging at first. But I do think that in general, the relative vessel size to the flap size tends to, if anything, be similar as the adult population. But I think at the end of the day, it is more challenging to do pediatric microsurgery, and I think these authors have correctly identified a very key element, which is it probably should be routinely performed by surgeons with vast experience, because I think at the end of the day, with some of the more challenging issues that arise in these pediatric cases, surgeons with greater experience tend to have better outcomes. If you look at it, the two senior authors in this paper have such a high success rate doing this, despite smaller vessel size, despite vasospasm, because they have such a large series and experience doing it. Again, I trained with these authors, and I can tell you that the second to last author, Dr. Levin, is probably the world's foremost expert in pediatric microsurgery. And he used to say every day during training, a day without the microscope is like a day without sunshine. And it just goes to speak to the amount that he's done. And so in my mind, I always urge surgeons with these cases, if they don't do a lot of this in the pediatric population specifically, to consider referring them to surgeons like the authors in this paper who have a significant experience, because they're the ones that in the end have the highest success rates doing these cases.
Dr. Sbitany, this is Jordan again. As a last question, in thinking about this, and I'm thinking back to, especially when we're doing in kids, like replants or some of the toe to thumbs, and they can obviously be tough to control in terms of compliance with limited activity and things like that. Are there any tips or tricks you have when you have these patients and they have to be 2 weeks bed rest, any sort of adjunctive things that you use?
Yeah, it's very hard in this population. The only additional trick that I have, especially in the lower extremity pediatric microsurgery population, whether it's an oncologic or a traumatic defect, one thing we can sometimes consider, especially in the teenage subset of these patients, for immobilization is to strongly consider external fixation temporarily. Now, it's not the most pleasant thing to have to submit a teenager to, but it's really the one sure way of immobilizing the leg during that 2-week period. It's something we've done routinely in the adult population when beneficial, and in the teenage population, it's something that I think can also be considered. In the younger adolescent population, it's a lot harder to do that, and I think really just aggressive splinting and casting is going to be the safest way to immobilize them for those first 2 weeks.
I think with that, we'll end our discussion of this article, but remember everyone to tune in to the other 2 articles that we'll be discussing on this month's podcast, as well as all our previous and future podcasts broadcast every month. Also, don't forget to participate in our monthly hashtag PRS Journal Club on Twitter, where we'll be able to interact directly with this month's selected article's authors. And once again, thank you very much, Dr. Sbitany, for joining us for this great discussion.
Thanks for having me. I really appreciate it.